Welcome to the Menopause Daily webinar. Today, our guest is Lynn Coates-Leisen, and our conversation is dedicated to women over 60. And they're still dealing with menopause symptoms and wondering if hormones are still an option for them. I thought those are very popular conversations inside our Facebook group, so I thought that would be a great topic for our webinar. So let me tell you a little bit more about Lynn. She is a family nurse practitioner and Menopause Society Certified Practitioner with 13 years of advanced practice experience. And she focuses on perimenopause, menopause, and hormone care. And she brings that individualized approach to this area. And today, Lynn, I'm so happy to have you here. And my first question to you is, why should women over 60 still be concerned about all things menopause?
All great questions. There are women who continue to have hot flashes and night sweats and symptoms of menopause well into their 70s and 80s. There's about 10% of women where this never goes away. In the 60s, it may be a few more, yet I would say anyone of the baby boomer age group, anyone from 1945 birth year to 1964, really got the short end of the proverbial stick when it comes to menopause care. In came the Women's Health Initiative study, brought forward by a bunch of well-meaning professionals trying to do the right thing. The media got hold of some statistics, ran with it, scared everybody, and by then it was almost too late to say, well, wait a minute, no, these statistics aren't quite as bad as everybody's painting it to be. But by then, women were basically throwing their hormones down the toilet. And so many women were suffering unnecessarily at that particular point in time. So why is that still important when we're aging? We need to look after our bones. We need to try and look after our cognition. If started earlier, there may be cardiovascular benefits. So when we talk about cardiovascular benefits, the number one killer of women, it's not breast cancer or other things, it's cardiovascular disease. And yes, there's this hypothetical 10-year window that comes from statistics. Well, let me just say maybe not hypothetical. It's there statistically, but that doesn't mean individually we shouldn't ignore and say, oh, you're having symptoms, too bad, so sad, off you go. We need to look at everything individually and say, yes, if you're having symptoms, hot flashes, night sweats, bone thinning, brain fog, just not feeling your best, unintended weight gain, cholesterol starting to go up. Yes, these are symptoms of aging, and we're all going to age whether we like it or not. But there's different ways to age. And if we can help you to age more healthily and readily with strength, ultimately that's what we want you to do.
So physiologically, when women reach 60, like what changes for them? What are the symptoms? What are things that they're dealing with when they hit that, mark?
The magic age of 60. The average age of menopause for Caucasian women is 51. There seems to be a significant amount of approximately 10 years of cardiovascular benefit for women, that they appear to have this significant amount of protection up until about 60 years of age. Then it seems like you jump over to the other side of the fence, cardiovascular disease starts to present itself more readily. So if we're able to approach that and in an ideal world, start women on menopausal hormone therapy earlier, great. But that doesn't mean after 60, that's still not important. If we can do things to help you with the brain fog, vaginal dryness, protect your bones, help your brain, and depending on circumstance, maybe stop rapid progression of cardiovascular disease, that's the things that are changing. The decline in estrogen over that 10 years, it's like this 10-year protection, and all of a sudden that 10-year protection is gone. And you step over that threshold of over 60 years of age, and it's like, well, wait a minute. Now my bones are thinning. I've tripped over the cat, and now I fracture my wrist. Where did that come from? And I'm not feeling my best, and now I've put on 20 pounds. Where did this come from? And now my cholesterol's gone through the roof, and now I'm really tired, and I'm still not sleeping very well, and I'm still throwing the clothes off, and I'm busy telling everybody it's hot in here, and I'm peeling off my cardigan, and everybody else is freezing because I've got the thermostat at 65 degrees Fahrenheit. These things are still there, and
My
When we
God.
talk about after 60,
Still there.
we can't ignore it. We can't just say that this, well, too bad, so sad. That's been the mantra to date. And I think we need to slowly but surely chip away at that as hopefully practitioners, physicians, NPs, PAs, DOs become more educated and more well versed in perimenopause, menopause, postmenopause, and aging well, especially after 60. The old mantra is, 5 years of hormones, then you have to stop. Why? No, you really don't. You really don't.
Definitely. And that's actually, I'm thinking that's a really good question. So if we are talking about hormones, how is this different? Hormones after 60 versus, say, hormones after 45, 50? Like, how do you distinguish that?
Great question. How do we distinguish that? We have to look at everybody individually. So when the groups, the expert statisticians, cardiologists, etc., looked and pulled the data, if we're looking over 60, there may have been already buildup of plaque in the arteries after that 10-year window has passed. There may be less plaque buildup in someone, if any, at age 45, while you've still got that estrogen. So if the estrogen is starting to wax and wane 45 to 50, early menopause at 45, the sooner we get someone on the protective benefit of estradiol, the better. If someone is 55 and they went into menopause at 45, that doesn't mean you're now 10 years in one day and you can't have hormones. It means let's look at you individually. What your cholesterol levels are. Are you putting plaque down in your arteries? There's ways to look at that. I'll come to that in a moment to get some better idea of your individual or potential risk. And if you are starting to put down some plaque, is it enough to be significantly concerned? Or if we're going to talk different ways of applying and giving a lady estradiol, giving a topical estradiol in a patch or a gel tends to keep plaque in check. It may not reverse it, but it tends to keep plaque in check. So there's already a little bit build up. It hopefully will keep it in check. So we're slowing, we can't slow aging. We'd love to think that we can. But if we can slow progression of some of the sequelae of aging, and if we're able to keep our proverbial pipes open and clean, we are one glorified plumbing system, whether we like it or not. If we're able to keep our vessels open, clean, and more readily and stop that continued buildup, then we're still getting some benefit, but it may not be the same significance of benefit versus starting at 45 versus 55 and beyond.
I see.
That answers the question.
Yes, I see. So now let's look at it. I'm thinking in reverse. For example, I am 45. I started the therapy. I'm looking good, but I'm feeling good as well.
Fantastic.
So now we are at 60. And now I'm thinking, okay, so I took this hormones. I did this therapy. I'm feeling good. Now I'm 60 or 60 plus. Should I stop, or when should I stop? What's your opinion on this, stopping?
Another excellent question. My opinion on that is we're only as good as the evidence and the data available to us today. And that's ever changing. And as healthcare professionals in whatever role, we have to do our due diligence to keep up with that evidence and education as much as we're able to do. So at 60, if you started at 45, you are in a very excellent position to have continued cardiovascular benefit from the estradiol and the bone protection and hair, skin, and nails and cognition, especially with some reasonable doses, and especially if it's paired with progesterone to protect the uterus, micronized progesterone, by the way. And no, you don't need to stop. Okay. It is reasonable to reassess every year and say, okay, well, you go for your annual physical, your annual exam, your annual checkup, whatever it is, and say, hey, how am I doing? Where's my numbers? What's going on? There really isn't a good reason in this day and age, as I say, we're only as good as the evidence available today and what's available to us now, to stop taking menopausal hormone therapy at 60 or 65 if there isn't an active breast cancer, if there isn't a blood clot where we don't know where the heck it came from, and if we're using topical estradiol, we should be pretty safe with many things. If there's an underlying clotting disorder that someone has, then we I wouldn't say even then we'd have to stop, but we'd have to be very careful about what type of estradiol we chose in the first place. Fundamentally, that would be a topical to the skin application of estradiol. So, no, in a nutshell, you really don't have to stop.
Still continue, still keep feeling good.
My oldest patient on hormones right now is 87 years of age.
Interesting. And I bet she feels pretty well.
Her skin looks amazing and she's as sharp as a tack. I hope I am as sharp as that at 87 years young. So all power to her.
Sounds good. So now, I guess let's talk about a little bit more serious topic, which is heart health. I hear, obviously, once you reach 60, people start talking about heart being one of the most important things for women to look at, once they reach this age. So what can you tell us about this?
It's a very interesting topic. There is, I'd say in some of the advanced hormone groups, a lot of information coming regarding the benefits of oral estradiol, not estrogen, not the stuff that comes from pregnant mare urine, but the oral estradiol, and its safety profile being somewhat similar to a topical estradiol. Now, I have to say that with a caveat, because again, if there's underlying health problems, especially a blood clotting disorder, we have to tread very, very carefully. That's one of the major exceptions. So yes, cardiovascular disease can be a significant risk, yet if we're preventing everything with the estradiol, then we're going to get those continued benefits. Percentage-wise, depending on who you read and what particular day, but let's just say approximately about 20 to 30%. As we're aging, less development of cardiovascular disease, bone thinning, and dementia if people are starting on estradiol and having a dose that is sufficient for them.
Okay, and you mentioned bone protection. So that's another big one, I think. Can you talk a little bit more about that? How does it help to protect bones? What should we do as women, especially since we are talking about over 60 today in that age category? What should we be concerned about?
Yeah, absolutely. Of course, healthy eating. Of course, exercising. Of course, strength training as much as you're able to do. Because the estradiol really protects and helps with bone remodeling. It helps to stop that breakdown of the bone that rapidly increases, especially that 10 years without estradiol. So after menopause, and definitely within that 10-year plus, there's an increased fracture risk. There, we need to look at things like optimizing our vitamin D, taking a reasonable amount of calcium, not overdoing that. As I said, the exercise, the weight bearing, the strength training, those things. But the estradiol, it's a positive regulator of bone health. It helps with those, stops the breakdown. It helps in some cases, even with higher doses of estradiol, and this is where we get very much into that individualized care. It has actually been shown in some cases to be positive on reversing and improving numbers on people's DEXA scan, the DEXA scan being the one that looks at people's bone density. Now, if someone's on a low-dose estradiol patch, that may not be the case. And so as we're aging, we kind of have to look at things individually as to what are we trying to achieve with our estradiol at what particular dose and in what particular form. It gets a little bit complex. That's why we have to look at everybody individually and say, okay, time out. What are we doing? How are we doing it? What are the potential risk factors for you as an individual? And what are we trying to achieve here? I see. So those are very much the bone benefits where, again, giving estradiol has that potential effect on the osteoclasts and the breaking down. And again, in turn, if it's given at sufficient doses, and this is very much not, I would say, in the regular guidelines per se, if given at sufficient doses in certain forms, there may well be bone remodeling and reversal of osteoporosis.
Wow. Very interesting. Yes, something definitely to think about. Also, I've been doing, in the group on Google, I've been doing some research about symptoms. And when I was preparing for our discussion for specifically, women about 60, I came across this syndrome, and it's called genital urinary syndrome. And for me, I hear urinary and my ears perk up and I'm like, what is it? What's happening? I need to know about this before I hit 60.
Yeah, absolutely. Let's get the elephant in the middle of the room and paint it bright red. Let's talk about vaginas. Let's just talk about it and bring it out there. Because it's one of those things as healthcare providers, practitioners, etc. If we don't bring it up, women don't bring it up. They just assume this is their lot in life. So genitourinary symptoms of menopause is all encompassing. So again, when the estradiol goes, things start to shrink, dry up, shrivel, be more prone to infection. So the estradiol, when given, and we give vaginal preparations, there's not one lady on the planet who cannot receive vaginal estradiol. I'm sure somebody's going to write in and say, well, I can't, or whatever reason. But in general, everything that I have learned and in my experience, anyone who's in that perimenopausal, menopausal, experiencing vaginal dryness and everything that is related to that, vaginal estradiol needs to be your new best friend. Why?
I see.
When we don't have that estradiol, the tissue starts to shrink. It atrophies. It thins out. That healthy, foldy, thick tissue we have internally, it's thinned, it's more friable. The urethra, the little narrow passage from the bladder to where the urine comes out of, where we pee from, that shrinks. The tissue becomes more alkaline. When there's estradiol in there protecting and estrogens, it's more acidic, which means any bugs that might decide to migrate from our tushy that goes in there, it has more of a ready passage because that protective from that acidic protection from the estradiol, it's gone. So there's increased pain with sex. Things start to shrink. Things start to atrophy, which means they shrink. There's more predisposition to urinary tract infections, which unfortunately for ladies when they're really in the latter years of life, that's when we see the ladies who sometimes might be asking a little bit crazily and we can't quite put our finger on it, and they've developed a urinary tract infection that's severe, then unfortunately it ends up that they're in the intensive care units. And maybe we could have prevented that if we just started some vaginal estradiol. So many benefits to vaginal estradiol. And it's one of those things that I'd like to think that healthcare practitioners are bringing it up at women's annual exams, physicals, pelvic exams, etc. But it's not always brought up. So I want people to be able to say, hey, we haven't discussed what's happening down here today. Can we have a little conversation about that, please? And feel very comfortable in doing that. I know it's a difficult subject to bring up. I didn't realize for people of my age, I'm in my 60s now, having a conversation with friends at coffee and they're asking me, starting trend. And I didn't realize how much people of my own age group, who are the boomers, were not educated about any of this. And she's frantically writing it down. It's like, well, what it is again? How do you spell it? And it made me realize
I had trouble.
Just how much people are not, and these are educated women, who are not in the medical field, have no comprehension of what should be available to them and what the benefit of something so simple, i.e. vaginal estradiol, can have benefit to them. And one of these patients is a recent cancer successor. So, we really had to talk about how can we help you here, because things definitely changed down there.
Yeah, totally agree. And that's definitely something to look to when you're aging. And even in my group, ages 50 plus, they already start having those problems. I see people complaining about UTIs and stuff like that. And speaking of complaining, actually, another big one I hear all the time, and I'm struggling with this as well, is sleep problems. So I hear everybody's talking about 45, 50, I'm unable to sleep, I only got 5 hours. So in our 60s, is it finally getting fixed, or are we still complaining and still having troubles with that?
Oh boy, we're still complaining, staring at the ceiling fan at 3 a.m. saying, please, can I get to sleep? No, it's still going on. What can we do about that? There's numerous drugs on the market, but there's also micronized progesterone. Nature's wonderful anti-anxiolytic sleep medication. And in our literature, it's mainly given to oppose estradiol. When we give estradiol, it can make the uterine lining thicker. We don't want it too thick because it can grow things we don't want, like cancers. We don't want that. We want to keep it thin. Progesterone's marvelous at keeping that uterine lining thinner. Yet, micronized progesterone indirectly works on GABA receptors. Those are the things that help us magically to sleep. Boy, I think progesterone micronized is one of the best things ever invented on the planet. Now, there's always a handful of women who are just a little bit different, and they're the exception to the rule. And I feel for those ladies, we may have to do things a little bit differently. Yet, in our literature, it's there for protecting the uterus, yet we know it helps with sleep so readily. So I have some ladies that come in my office that don't have a uterus, that had a hysterectomy maybe 5, 10, 15 years before. I personally have no problem putting those ladies on micronized progesterone. They're getting the benefits of the estradiol, but they're still not sleeping. We may have helped with the hot flashes, we may have helped with things, but they're still not sleeping. So that indirect conversion to GABA is really helping them to sleep, to a point where I've had ladies, we've managed to take them off their SSRI antidepressants. We've been able to wean them down off some of the stronger controlled medications for sleep by something as simple as a generic micronized progesterone. Again, very patient specific. This is just what I see in my personal practice and things that I've learned from some very learned physicians along the way. Thank you very much. But again, these things can be very beneficial. And we have guidelines always in practice, but what happens when you get to the end of the guideline? We don't want to gaslight a lady again and say, sorry, must be you. No, that's not it. There's other things we can do that go beyond the guideline, and we have to offer that to people.
So, yes, and you mentioned SSRI. So that's, I think, another great segue into anxiety and depression, because that's another big one that I noticed women are complaining. So what happens there when we hit 60? Is it getting better, or some still feel the symptoms? What should they do about it?
Very good question. I am not a psychiatrist. Let me just preface by that. But I am familiar with some of the first-line medications that can be given in primary care. So if a lady has been put on a medication, SSRI, for anxiety, depression, and she's 60, but she started to have these symptoms around in her early 40s because the hormones were waxing and waning, she was on the roller coaster, and she's feeling pretty even, then there's always going to be a potential misbalance in our neurochemistry, with or without the hormones. Some people will need these medications. Some people, if we get the hormones right, may not need these medications. May not. There are some ladies where we've tried to reduce them and it just wasn't for them. They didn't feel good. The anxiety, depression returned. No, those ladies will continue on that slow dose, that low dose, and slowly get to a dose that's effective for them. So yes, the hormones are estradiol, progesterone, and testosterone. They're neurohormones. As that's starting to wax and wane in our body, perimenopause, menopause, and postmenopause, we don't have those benefits. Again, starting someone who may be appropriate, we've gone through benefits, potential risks, individual, looking at that, and starting on those hormones even at 60 plus. Yes, you can do that. And yes, we may be able to reduce or wean you off some of those SSRIs, but we can't make false promises. It might not work for everybody. So again, how do we get to this place? Yes, the neurohormones were affected by the fluctuating hormones, then the lack of hormones, and various ways to address that, either with SSRIs, SNRIs, without, and or with hormones in collaboration.
Okay, all right. So I'm thinking another huge topic in our group is sexual health. Always brings us a lot of comments, a lot of discussions. So as far as sexual health, is it still a hot topic in 60s? What do you see in your practice? Yeah. What can you tell us about this, when we get a little bit older?
Absolutely. Libido is a feeling, again, driven by neurohormones. It's an experience. There can be many factors that come into that. Many ladies into their 60s and 70s are having a very viable sex life. Other ladies, for whatever reason, will be just like, I'm done. There is no normal. It's what's normal for you.
Okay.
There is a case of, if you never want to have sex again in your life, that's fine. If you do, but you feel limited because things are uncomfortable, things are shrinking, things are dry, and or the libido has just gone, it's just not there, then again, there's things to address and look at. And so vaginal dryness, tightness can be a significant off-putting experience for many women. It only takes one go of that being really painful and like, I don't want to do this again. This is going to happen. So it's already in the back of the mind before they even go there. That's why vaginal estradiol started earlier is a great way to go. Vaginal DHEA is another one. We didn't talk about that. And then testosterone for women can also be a wonderful addition. Now, there is no FDA-approved product for women in the United States.
Okay.
The Australians, New Zealand, the British, and the South Africans, yay, they got one. We don't have one in the United States. There's different ways to go about this, and different state laws kind of dictate who can't, under what circumstances can this be prescribed. I'm in California. I have many women on testosterone. Testosterone, honestly, I've seen very varying responses for women where it's like, yay, this is the best thing. Everything's back. Woohoo. And then I've seen other ladies like, this just isn't doing anything for me, even if I've literally increased that dose 6 times. So testosterone may be a fantastic thing to help the libido, along with taking care of vaginal health.
Okay.
It may not be the magic bullet for all women that they would expect it to be. And again, we have to look at dosing. I wish I could tell everything in the amount of time that we have, but we have to consider the dosing. And just like any other medication may be dose dependent, let's just say, for example, a sleeping medication. 0.5 milligram of something might be good. I'm just saying this, and not particularly medication might be good for one, where the next it might be 4 milligrams hypothetically. The same could be said for things with testosterone. So we're looking for help with that. So to summarize that, many ladies want to have an active sex life. Things that get in the way, typically the vaginal dryness, the discomfort, things shrinking. There's ways to address that. Testosterone, depending which state you're in the United States, may dictate how and when and how it can be prescribed. I do see significant benefits for many ladies with testosterone. My preference is for a testosterone cream, but there are other ways to give that. And depending on, again, individuals.
Makes sense. Yeah. So now we talk about hormones, various hormones, but I think what we also should talk about a little bit is, when should a woman be not taking hormones? Like, what are the situations that they should be aware of where they say, okay, this is not for me?
Okay. So if they're not feeling better, if we've adjusted the doses, let's say 4, 5, 6 times, and it's just really not helping them to feel better, that's something to consider, because we want the benefit. Yes, there's cardiovascular benefits, and there's bone benefits, and there's brain benefits. Ultimately, if you're feeling much better with those hormones, fantastic. Yet if you're still feeling lousy with them, you have the choice to take them or not take them. Active breast cancer, especially estrogen receptor positive. That is one of the reasons where you may not be taking hormones. Now, there's a lot of noise in the background, quietly and maybe not so quietly in some circles, about can we restart that after breast cancer?
That's an interesting one.
There's a great book out there by Dr. Avram Blooming called Estrogen Matters. If there's any breast cancer successes out there, I would strongly suggest that they read that material. And the other people who cannot take hormones are people who have a blood clot that came out of, we don't know where it came from. We call that an unprovoked clot. We have no idea why someone's having these clots and they're coming off. Now, again, we got to look at the different types of estrogens. We've got the estrogens and we've got the estradiol. And if we're giving it a topical, there may be a slightly increased risk. But again, we don't want to exclude everybody from the table and saying absolutely not. But if there are certain blood clotting disorders, we absolutely really don't want to consider oral estradiol. And there are a couple of instances with certain clotting disorders where we may want to tread really carefully, if at all, with a topical estradiol. Now, even said that, these ladies can still have vaginal estradiol, so that's still on the table.
That's good to know.
These ladies can also consider progesterone, micronized progesterone, and they may also consider testosterone. So it may not just be all about the estradiol. And then the other group who may not have this, if someone's had a significant history of strokes, heart attacks, obviously there's an increased risk of cardiovascular disease with those. Those are the ladies I'd say, we might want to do things, think about what else can we offer besides hormones in those situations. So again, very much an individual type of approach. But typically, blood disorders, history of stroke, heart attacks, the unprovoked blood clots, active cancers, breast, those kind of things, that would be like, not now. That doesn't necessarily mean not ever, but we have to tread very carefully and look at everybody individually. And even looking at people individually, there may be times to say, I'm sorry, I don't believe this to be in your best interest.
Mm-hmm. Okay, yes, that's a very important discussion here. Also, now switching gears a little bit, and just when I research through my group, I look what women are talking about, and some women obviously have all kinds of questions. And what comes to my mind is when I look at all of these discussions, some women, they know more than others, or they just research a little bit more, or they heard something somewhere and they're bringing this into the group as their question. So I start thinking about if there is still some kind of misinformation or misunderstanding, even though you would think information is available right now. So what is your, what do you see in your practice when you see those women, when they come to you in the age of AI, in the age of, Google, and everybody can Google anything? Do you still see misconceptions? Do you still see misunderstandings? What are those, and how do you go about handling those?
Absolutely. So AI is one step up from Dr. Google. And AI can, yes, absolutely, which may be a good thing. And in some cases, it's not such a good thing, because AI can hallucinate. It can pick things. It can come up with things that I've actually had chats with AIs and argued with AIs about hormones. It got very interesting. And it can go back to the original information that it pulled from, even though you told him that's not the best information to pull from. So one of my patients is actually a male patient he's actually a retired rocket scientist. And I said to him, okay, Mr. So, tell me what your opinion is on AI. And his answer to me was, what? Artificial ignorance, garbage in, garbage out. It's only as good as the information it's pulling from, just like practitioners and providers, be that NPs, PAs, MDs, DOs, whoever it is. We have to have the best evidence and information available to us to give us the best evidence and information for you as an individual. I would say that AI may be able to give some reasonable generalized questions to things. And if someone's paying for the best version of Claude AI, they're paying $120 a month, they may get some reasonable information. The free stuff like the Google AI, you might not get the best information. It's constantly learning, which is great, but it can go back to what it was doing a few months ago, which was absolutely wrong. Why it does that? Good question. Be cautious. It's good for overall education, asking questions, simplifying questions. And again, just realize this can be very much in generalizations. It might not be the best information for you as an individual.
I see. So for a woman over 60 then, what do you think should her overall approach be if she wants to lead a healthy lifestyle, enjoy her life? What is the overall, outlook that she should have? What should she do? How she should approach her life when she reaches 60s and beyond?
Absolutely. In an ideal world, we've got somebody into healthy eating, exercise, good sleep, clean water, protein, fiber, low carbohydrates, water, moving their bodies, enjoying their life, whatever it is, good hobbies, good employment, whatever they do, family support, whatever it is for that particular individual. I will tell anyone in a polite version who comes into my office, we can't outpatch, pill, or inject yourself out of a less than ideal lifestyle. So if someone wants to sit there and, my heritage is British. British women like their wine. Well, some of us do. At the end of the day, one has to choose, especially with aging, that 3 glasses of wine are definitely not in your best interest. Sitting on your backside and not moving isn't in your best interest. Alcohol is not going to help anyone. Neither is the 2 bars of chocolate or the bad food or the fried food. We've got to move our bodies. We've got to maintain our muscle. The muscle is going to decrease as we're aging. We're fighting what the inevitable is. But we can go on our journey as we go to meet our maker in our latter years, hopefully kicking and screaming, saying, wow, what a ride that was, versus being with a walker or a wheelchair and saying, how did I get here? So
good
healthy
point.
approach, and the more you can do that for yourself. Yes, patches and hormones can be an excellent adjunct to everything, but as I will say again, I'll just stress it, you can't patch, pill, or inject your way out of a less than ideal lifestyle.
True. And what I'm also thinking is it's no matter what age you are, sometimes it's just difficult to start. Like I might be feeling, I need to do something about how I feel. Doesn't matter, am I 40, 50, 60? But I think at 60, it's also important. So if I'm somebody, I don't know where to start, I want to feel good, like, can you outline maybe like a roadmap or some easy flow chart, where to start, where to go if I want to, improve how I feel?
Absolutely, all valid questions. I would say the Menopause Society is a good place. There is also the International Menopause Society that also has a lot of great information on there. They did have a site called Menopause Martha that had a lot of wonderful information.
Mm-hmm.
There are probably numerous places to download checklists. The checklist is only as good if you fit into a nice cookie cutter little checkbox. Yeah. I would say just take 10 minutes to sit down and write for yourself. What am I experiencing? What's different? What don't I like? And then what would I ideally like to achieve to feel better? You then have your own personal roadmap when you walk into whichever practitioner, physician, counselor, coach's office to say, this is all the stuff that's really dragging me down right now. I'm not too sure what to do about it. Where would you suggest we start, and what can we do, and what advice would you give me? So again, very individualized. A checklist is great, but it's not the same for everybody. And if it's got 10 boxes, but you've got 15 things, then just be honest with yourself and write down what you're experiencing, and then go and ask for help.
I see. Okay, so maybe tonight I'm going to start with writing down my things and building my list. I think
build your list. Yes.
Yeah. So ladies, let's start building our lists, right? And we like, if you feel that you want to complain, which is fine in the group, obviously, but I definitely would like to encourage everybody, if you want to get out of this state, we need to start doing something about it, even small thing. And I think Lynn is absolutely right. I agree 100%. So we need to start building our list, what we're trying to achieve, what our issues are, and kind of go from there, and then work with the provider that is, somebody that we resonate with. So speaking of resonating, and speaking of, if you felt that Lynn, she covered, majority of the issues that you're experiencing, and if somebody wants to work with you, Lynn, and go on this journey, prepare their checklist and bring it to you. How would they go about it? How would they start working with you? Tell me.
Absolutely.
What's the best way to reach out?
The best way currently is through the website for the corporation I'm working for currently, which is Conejo Valley Primary Healthcare, and I believe you'll have that in the link. And again, at this point in time, my license is for California. And so coaching in other states becomes a little bit, there's a little bit of a gray line there about what exactly that entails. So for my California ladies, I am there at this point in time to be able to help. I do have a brick and mortar clinic, so I see many ladies in person, which is excellent, because if something's going on with skin, vaginal health, I can literally lay eyes on it versus waiting to see someone. In California, I can also offer telehealth for ladies, which means not only advice or coaching, etc., but of course in California I can prescribe accordingly. And it's not just about hormones. We've got to look at the whole big picture. What else is going on with your health? What's going on with the stresses in life? With one thing in midlife and beyond, I would say when ladies get to 65, 70, maybe things have slacked off a little bit, but I would say even women who are choosing to have families later, we're now dealing with aging parents. We've got significant careers. There's teenage children, our children in college, and all the problems related to that. There's only so much room on this plate before things start falling off and we start to be feeling overwhelmed. I would say, ladies, cut yourself some slack. It's a very busy phase of life. And again, just write another list. I'm a big fan of 3 things on a Post-it note. If those 3 things are all you're going to get done tomorrow, hey, you got 3 things done. It's okay.
Totally agree. Well, thank you so much. It's been very helpful.
Pleasure.
And what I do think that everybody's talking about 40s and 50s or late 30s, but not many practitioners actually address older ladies, 60 plus, 70 plus, and as you mentioned, even 80 plus. So that's maybe we should do a
Yeah.
next webinar for even older
Absolutely.
crowds. So, but thank you so
Absolutely.
much. So I'm hoping that we will talk more and we will
Yes.
discuss various topics that are also urgent for this age group and bring
Absolutely.
some more information to our listeners and viewers. So thank you so much.
It's been my pleasure. Thank you so much for inviting me, and I look forward to chatting with you again in the future.
Okay, thanks.